This conference will now be recorded.
Hi, my name is Jess Church. I'm a public health dietitian with the Utah Department of Health, and today I'd like to talk with you about food access and the connection with health and some food insecurity screening. So this is just an overview of what we'll be talking about today, sort of what the food insecurity, food access definitions are, why it's important to address food access and what sort of health burdens there are related to poor food access, who are the folks that are impacted by it, and then we'll talk a little bit about food insecurity screening and some other resources available. So what is food insecurity or food access? So just to give a little background on food insecurity, USDA defines food security as access by all people at all times to enough food for an active, healthy life. Conversely, food insecurity is considered a household level economic or social condition that's characterized by limited or uncertain access to adequate food. So in a perfect world, everyone would be food secure. So we just talked about food insecurity. Now, when we talk about food access, that's a little bit more of a broad definition. So this considers multiple factors related to accessing nutritious food, including geography. So there's some neighborhoods often referred to as food deserts, where food insecurity and lack of grocery store access might overlap. The map that you see here is a 2015 map showing areas with both food insecurity, so that's that USDA definition we talked about, and lack of access to a physical grocery store. In urban areas, that's at 1 mile, and then in rural areas on this map, that's at 10 miles, so no grocery store within 10 miles. I also want to point out that this map doesn't account for actual income or cost of food or vehicle access for those areas. So you might also think about in rural areas, sometimes not only is there only one grocery store in a county, but the food in that grocery store might be quite a bit more expensive because it takes a lot more effort to get it on the shelf in that area and to keep it stocked and fresh and that sort of thing. So in Utah, we have the following statistics that you guys have seen here on this screen for sort of what that looks like in terms of how many people are affected by having both low income, low access. So why is it important to address food access? Households with limited resources are often forced to prioritize their needs and make some pretty tough choices. And that can lead to a lot of poor health and economic outcomes. One classic example that you might see is food versus medicine. So you might see a problem between where folks are having a hard time both with poor diet and medication adherence, and they're sort of happening in a cyclical kind of cycle. So in 2014, Feeding America did a nationwide survey of food pantry participants, and they found through that survey that their clients were frequently reporting choosing between things like food and medicine. So about 74% were reporting that they were choosing between food and medicine, or food and utilities, about 60%, food and transportation, 67%, or food and housing even at 57%. And oftentimes households might also be using coping strategies in order to meet their food needs, and those coping strategies can include things like receiving help from friends, about 53% of participants, watering down food and drinks. You often see that with milk, with infant formula, with juice, things like that. 40% of participants. Purchasing inexpensive or unhealthy foods, 83%. That's one that we think of pretty commonly. Growing food in a garden, on the other hand, only 23%, but I would definitely think about the time required to grow food in a garden. I mean, I grow food in a garden. It takes me a lot of time and manual labor to do that, so I have the privilege to be able to grow food in my backyard. So more than half of all the households in that survey were reporting having to choose a bunch of those different coping strategies to deal with these kind of tough choices. So I also want to help you guys think about sort of what that cycle of choices would mean for a family and their upward mobility, particularly kids in that household. If they've experienced that for a long time, that might really affect the trajectory of their life and what they're able to achieve in terms of economic stability and upward mobility over time. So it might be surprising to learn that food insecurity is associated with obesity and other related diseases like diabetes, but just consider the costs of fresh, healthy food, but also especially I mentioned that time burden. Think about the time that it takes to actually go grocery shopping or procure the food, and then the time it takes to prepare it versus costs, and again thinking about time, of prepackaged and high caloric density but low nutrient density foods that are a lot more convenient to eat. I'm a dietitian, and I will admit to you that there have been times in my life where I don't have time to prepare a perfect healthy meal, and even I have found myself going to a drive-through at a time like this, right? So we are all humans, and we can relate to that. A lack of nutritious food due to that kind of financial stress, again, leads to this sort of cycle. Inadequate nutrition can lead to poor disease management, and then you need more time and money resources to respond to worsening health crises. And all of this poor health is leading to less money for nutrition, medical treatment, and other kinds of essential needs, and then perpetuation of poor disease management. So it can be a pretty vicious cycle. So that same study that I mentioned, the 2014 Feeding America Food Pantry Client Survey, also found that about 58% of households had a member with high blood pressure, 33% had a member with diabetes, and then those rates were even higher if those households had seniors present. So they would have higher incidence of high blood pressure and diabetes. And we actually see quite a few seniors with issues related to food insecurity. So this slide shows you a link to a really great video. It's less than 2 minutes long that helps to illustrate that connection between hunger and health. If you have a couple of minutes, I highly recommend giving it a watch, but for the sake of the recording, we're going to keep moving along here. So I mentioned those time barriers to healthy food access, and I just want to talk a little bit more about that. So there's actually research and evidence that shows individuals who spend more time preparing food have higher diet quality, fruit and vegetable intake, versus those who spend less time preparing food. And those that spend less time preparing that food will often spend more money on food away from home and eat fast food more frequently. So before jumping to any conclusions about time management priorities, I would also consider that a lot of lower wage earners might be working more hours or more than one job to make ends meet, and that leaves a lot less time for things like meal planning, shopping, and meal preparation. Same thing if you look at households with all members who are employed at a low wage and with multiple jobs, it's kind of a compounding issue in that situation. These households might also have less access to a vehicle, and so if you think about a quick trip to the store to buy some fresh food, that's a little bit more challenging in those kinds of situations. So it takes a lot longer to get on a bus, and you don't have the ability to carry as much food. So there's a lot of other challenges there that people might be experiencing. So here's a little bit more evidence on the connection between food insecurity and chronic disease. The NHANES data, which is sort of one of the gold standards on nutrition out there, shows that food insecurity is greater among those that have diabetes, hypertension, coronary artery disease, congestive heart failure, obesity, etc. And among folks who have diabetes, we also see food insecurity associated with a lower intake of fruits and vegetables for those folks, and poor glycemic control compared to those without food insecurity. So here's some Utah-specific data for you. This is from the Behavior and Risk Factor Surveillance System, BRFSS, 2015 data. So food insecure adults were significantly more likely than food secure adults to consume the recommended 5 servings of fruits and vegetables per day. They were also more likely to report poor mental health, or fair or poor health, and also to be obese. So this data supports a very clear need to improve the community and clinical linkages for patients who have food insecurity, and also to approach these issues as a team. So this is a report from the Public Health Institute that kind of tried to calculate the economic burdens of food insecurity related to health. So the estimated impact nationwide in 2015 of food insecurity on healthcare costs was $78 billion, which is pretty staggering. And in Utah, those numbers translate to about $500 million to $1.2 billion with our food insecurity rate in Utah of 11.4% in 2015. So now the who. Who is impacted by food insecurity? So this is by no means all of the people who are food insecure. This is just looking at our SNAP population. And SNAP, for those who haven't heard of it, is the what used to be referred to as the food stamps program. So it's the Supplemental Nutrition Assistance Program. And the folks that are receiving those benefits in Utah are greater than or equal to 130% of poverty. Only about 2/3 of Utah eligible households are participating in SNAP. And participation rates are typically higher in rural areas versus urban. And this is a really interesting part. So only about 11% are non-disabled, non-elderly, and childless. So when we talk about the folks who are, are workers who are accepting federal benefits, this is often kind of the political rhetoric that you might hear as being, too many working or work-eligible adults taking advantage of benefits. That number is pretty low here in Utah. We also have the other 89% are households that have children or seniors and also non-elderly adults who have disabilities. So that's the majority of the folks that are benefiting from that program that are reaching out for food assistance. So this chart, it might be kind of difficult to see, the print's a little bit small, but it's really talking about what the national disparities are. We see food insecurity rates much higher in households that have children, more among females if you think of maybe your single female head of household. And also we see some racial and ethnic disparities, higher rates among Black and Hispanic households. So now we'll get to ways that you might be able to identify food insecurity in your patients or clients. Before we talk about what the actual screening looks like, I think some of the questions that come up most frequently in folks that haven't talked before to their clients or patients about food access are, how do I be sensitive about this? It's a pretty difficult topic at times for people to talk about. So I want to touch on some points related to that. So some things to keep in mind, some tips here, and these all come from a really great resource that is a toolkit for pediatricians in addressing food insecurity. It's developed by the Food Research Action Network and the American Academy of Pediatrics. And so these tips are to, number one, screen all of your patients and clients. That way you're not singling out a specific group. And that's a pretty good rule of thumb. So you can't necessarily see food insecurity. So it's really important to make sure that you look beyond any potential biases that we all carry to screen all patients and clients. If you are screening verbally, make sure to try to be sensitive to children that might be hearing that screening. So either do so when children are not in the room, or maybe they're distracted by something, so that parents won't feel uncomfortable about talking about these issues in front of their kids who really should not have to worry about food being on the table or not. Also consider privacy and make sure you ask those questions away from others. And one really good way to normalize some of the statements that are often in these screening tools would be to put your patients or clients at ease by saying something like, I see so many people who are having a hard time affording food. And many of those people need assistance at some point in their lives. So I'm just asking all of my patients about food access. So then it doesn't feel quite as directed at them in particular. Also, you should always be using your patient or client's preferred language for those screening questions. The screenings that we'll be talking about have been validated both in English and in Spanish. I recommend looking out for other tools that have been validated in different languages if you have a different population than those two. But at least it's a starting point, even if you can't find those resources. So some other tips, make sure at the end of the screening, if you identify somebody as having food insecurity, they should get referred to some kind of assistance resource. So referrals or referrals to like a social worker or something like that, or food assistance resources. And you can also kind of emphasize that your recommendations for food assistance are often as important as a prescription for medication. Both of these things are intended to improve health, so you should try to emphasize that. You can also normalize participation in food assistance programs by having some environmental cues, like maybe you're wearing a button on your shirt that says, ask me about different food access resources, WIC, SNAP, school meals, or you've got posters or flyers throughout your space that can help destigmatize your patients from asking questions about food assistance. And you can also, if you feel comfortable sharing personal stories, experiences that you or someone else has had with food insecurity or poor food access. That can often help put folks at ease as well. Of course, make sure that anything you share is HIPAA compliant. And do make sure as well to consider that many immigrant families might have mixed immigration status. So even if you know the immigration status of one household member, they might not all be the same. And so, for example, children often might be eligible for benefits where parents are not. And families can feel really anxious and stressed about applying for federal benefits if they're worried about their own immigration status, but oftentimes they can apply for benefits for a child without having to reveal their own immigration status. And so that can be really reassuring to let them know. I should also mention to make sure you reach out to anti-hunger organizations to help address specific resources in your state and community. Excuse me. So, and the last three, these are really important sort of motivational interviewing type of tips for you. So acknowledge, commend, and reassure. Acknowledge that discussing this topic can be difficult, and especially for caregivers, admitting that there's some kind of a financial struggle can be tough for people. So acknowledge that it's hard to talk about. And also commend your clients and patients for being honest and for sharing those things with you that are hard to share and to admit. Sometimes there's shame and embarrassment associated with that, and reassure them, especially if they are a caregiver, that they are not, a bad parent or partner or caregiver for needing assistance and for reaching out. And then reassure these folks that they're not alone and that many people have financial struggles at some point in their lives, and it's okay to reach out for help. Okay, so this is a 2-question screener that has been validated against the gold standard of assessment for household food security, which is our USDA Household Food Security Screener. And it was validated in a racially diverse U.S. sample. So this algorithm comes from the Nutrition Obesity Research Network and is also known as Hunger as a Vital Sign. There's some tools and resources out there to help incorporate these types of questions into an EHR, and I will talk about those resources toward the end. So at the top of this screening, you'll see recommendations to screen all adult patients, and this particular one is for adults, at least once. And then your high-risk patients really should be screened annually. And there's criteria here for what high-risk means. So some demographic information would be if they're 50 to 65 years old, enrolled in Medicaid, socially isolated, and then they might have clinical indicators that make them high risk as well, like frailty, malnutrition, unintentional weight loss, poor appetite, pressure ulcer, diabetes, depression, apathy, poor medication adherence, and obesity. So the recommendation to screen annually, just to acknowledge that people's circumstances change pretty frequently. So within the course of a year, a lot can happen. So these are the questions. So for each statement, and sorry, I'm going to go back to the previous slide for a moment. So you'll note that they state in this protocol to preface all your questions with that statement of, I ask all my patients about access to food, and I want to make sure that you know the community resources available to you. And many of these resources are available free of charge. So for each statement, please tell me whether the statement was often true, sometimes true, or never true for your household in the past 12 months. I or we worried about whether our food would run out before I or we got money to buy more. So these are tailored to be able to ask to an individual or a group. You can use either one, either pronoun. And the food that I bought just did not last, and I did not have enough money to get more. So a response of often true or sometimes true to either of these questions would indicate that this person or our household has food insecurity. And you can see that in the next slide. So this slide kind of gives you what to do next. So step one is to assess for any coexisting risk factors for poor nutrition. If they maybe have limited proximity to food, think about their transportation. Do they also have other issues that might affect their nutrition status, like frailty or cognitive decline, that make it difficult to prepare foods, or you get too tired even in some cases. Dental problems, social isolation, lack of appetite, which can be a side effect of medication oftentimes. Changes in taste can be pretty common too with certain diseases and medications. Limited capacity to prepare food or feed oneself. If they have any challenges with activities of daily living, so anything that might impact or impair their ability to prepare foods. Lack of cooking and storage equipment. That one is one that's often overlooked, and you might be really surprised asking questions about that. That folks might not have a full stove or refrigerator or running water or whatever that might be. Their living situation may not be the norm of what you've experienced, and particularly if you're in certain rural areas. I know we have them in Utah, particularly if you're in San Juan County on the reservation down there. It's very common to have no refrigeration, no running water, and limited means for cooking with what might be a traditional stove to most folks. So step two would be to actually code for food insecurity. If you are doing this in an EHR, for example, you can enter a code there that indicates lack of adequate food and safe drinking water. You can also assess weight trajectory if they've been gaining or losing weight. Doesn't matter what size a person is. Food insecurity doesn't care about size. So also refer to resources. So that's your step 4. And I've got a couple slides on that. And then if you have talked to a patient or a client about food insecurity, make sure to follow up at the next visit. Ask if their referrals to those resources were successful. Keep an eye on their weight trajectory. And maybe screen for food insecurity again. That recommendation for annually is, at least annually, but you can always do more than that. It might be also helpful for you guys to know that at the national level, the VA is actually beginning to implement a system-wide EHR-based food insecurity screening for all veterans, unless they're a resident of some kind of nursing home or long-term care facility. And then in their EHR, they can indicate whether there was a referral, no referral needed, or a referral to social work or to a dietitian, or if they were already receiving services or assistance, or if for some reason that screening was not performed. So sorry, this slide got a little messed up, but this is just food insecurity resources, my little Lego pizza man. So on this same protocol that we've been looking at There's some suggestions here of where to refer folks who are food insecure for resources and help. There's a couple of national hotlines here, so the National Hunger Hotline, or 211. If you have a senior patient or a client, there's the Elder Locator. So those are just a couple of resources there. Okay, so these are a couple of different food assistance resources out there. Eligibility varies quite a bit by program, but generally a couple of cutoff points will be 185% of federal poverty level, which is one that would qualify folks for free school meals, free lunches. And, you know, if there are children in the household, relieving food insecurity for one part of the family really affects that whole household, so do keep that in mind. And 130% of federal poverty level is a common one for reduced lunch or for SNAP eligibility. Again, that's what used to be called food stamps. And also, if they are receiving any other federal benefits like Medicaid, sometimes those benefits can be used to directly qualify them for food assistance programs as well. So I'll just give you a little bit of information about a couple of these. SNAP, in Utah, the average is about $116 a month per person, or $1.27 per person per meal. So note that that's quite a bit lower than the average meal cost. So it's generally not enough to meet 100% of needs. So just so you kind of understand what that benefit looks like. So WIC is the Women, Infants, and Children program. That's something that can be of assistance for pregnant, postpartum women, infants, and children under the age of 5. Again, think about this as a whole household. Food insecurity doesn't affect just one person at a time. It's whoever is living in that household. So if there are any folks that in the house that would qualify for that, that might be one to look at. So WIC is one that's issued in volume of food. So vouchers for WIC can only be used on certain WIC qualified foods that include things like fresh fruits and vegetables, dairy, whole grain, cereal, eggs, beans or legumes, peanut butter, infant foods, infant formula. The National School Lunch, Breakfast, After School Meals, Free Summer Meals program, excellent resource for any household that has kids. In Utah, there's quite a few free summer meal sites throughout the state. Sometimes they're at really convenient locations like parks, and most of those sites are open to anyone for free meals for kids. So not just folks that are already receiving free school lunch during the normal school year, for example. Food pantries sometimes will require less documentation than federal nutrition programs and can be a little bit more flexible and open to those that are needing sort of something like temporary emergency assistance. For example, in recent time, we had a government shutdown where pantries were open to a lot of federal workers during the government shutdown, supporting food for their families. So food pantries can be a pretty good resource for that. However, more frequently, they've been pretty common staple for a lot of households to get their food. They are receiving benefits if it's just not quite enough to alleviate their food insecurity. So the Utah Office of Aging and Adult Services would be the one to go to help connect your older and disabled adults to resources like Meals on Wheels, congregate meal sites, and things like that. And oftentimes that might be a local senior service center. So these resources that we just went through, you see that column there for local information and resources. I would consider reaching out to either the local anti-hunger organization in your area, or which in Utah we have a statewide anti-hunger organization, Tongs Against Hunger. Highly recommend working with them. And or local health departments. There's also USU Food Sense is the SNAP education program, or the formerly Food Stamps. It's a nutrition education program that's focused specifically on low-income adults. Your county extension office will have access to those resources and know where to direct you for that. So the Nutrition Obesity Policy Research Evaluation Network, NOPREN, also has similar algorithms like the one that we just went through that are specific for pediatrics and patients who are living with diabetes. So you can follow the link there to find those specific algorithms. I mentioned that toolkit from American Academy of Pediatrics and Food Research Action Network. That's another great one, which is where all of those great tips came from for how to approach food insecurity screening sensitively. The PRAPAIR, I don't even know how to say that acronym. So this is an implementation and action toolkit developed by National Association of Community Health Centers, and the acronym stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. This toolkit is available free online, and it contains all kinds of resources, best practices, lessons learned, help guide, etc. for any users interested in each step of the implementation process to screen for social determinants of health, including food insecurity. They also have some workflow diagrams and even templates for electronic health record collection of that data. And they have system-specific templates, so they have EPIC, eClinicalWorks, GE Centricity, NextGen, and have some sample reports and examples of interventions that you could use to address a specific social determinant of health. So I highly recommend checking that out. And last, but most certainly not least, Tongs Against Hunger I mentioned as the statewide anti-hunger nonprofit in Utah who is working on public policy and advocacy related to federal nutrition programs. Sometimes they get calls. Just know that they're not an emergency food provider, but they can direct you to where those resources might be. And they also do presentation and training, so definitely reach out to them if you're interested in presentations, whether it's for schools or community organizations, clinics, etc. These guys are really great. They know all the details of where to find resources and how to connect folks, and also even to get people trained within your organization to help connect your patients and clients to those resources. So that's all I've got for today. I appreciate your time and hope that this information will be useful to you. Thank you.